All right. Thank you everyone for your patience. We are excited to present our webinar called Capturing What We Do in Rehab, Defining Treatment Ingredients to Enhance Interdisciplinary Communication and Clinical Reasoning. I am your host, Susan Lin. I am the secretary for the ACRM Rehabilitation Treatment Specification Networking Group. And we have some fabulous speakers today. I also wanted to let you know that we are taking questions through the chat feature of Zoom. So as you think of questions, go ahead and type them in, and we'll have time at the end of the presentation to address as many questions as we can. So our speakers today include two speakers from Shirley Ryan Ability Lab. First, we have Julia Carpenter. She's a clinical practice leader for speech language pathology and a research speech language pathologist in the Center for Aphasia Research and Treatment at the Shirley Ryan Ability Lab. Julie's clinical interests are in acquired communication and cognitive communication disorders, and her research interests are in outcomes research and aphasia treatment. Next, we have Holly Paxson, who is a board-certified clinical specialist in neurological physical therapy, and she's also the therapy manager for the Legs and Walking Lab at the Shirley Ryan Ability Lab. She specializes in the treatment of patients with neurological conditions, including stroke, brain injury, and vestibular dysfunction. We also have two speakers from Moss Rehabilitation Research Institute. We have Andrew Packel, who is a board-certified specialist in neurologic physical therapy, working mostly with individuals following stroke and traumatic brain injury. He is currently the locomotor coordinator at Moss Rehab, just outside of Philadelphia, Pennsylvania. And finally, we have Mary Ferrero, who is the education coordinator for the Brain Injury Center at Moss Rehab. And she's also the clinical knowledge translation liaison for the TBI Model System Project. And she's also the coordinator of the Advanced Practice Occupational Therapy Fellowship Program in Physical Rehabilitation, which is accredited by the American Occupational Therapy Association. We will start with Andy Packel giving a review of our learning objectives. And I will stop the share and send it over to you, Andrew.
Very good. Thank you for joining us all. You're able to see my screen? So we're just going to
presentation mode, Andy. You're not in presentation mode.
Thank you. Excellent. So to start off, we're going to talk about the RTSS and its relation to clinical reasoning. So that's what we're going to begin with, and we'll talk about how the RTSS can help identify treatment ingredients as well as targets. And we're going to talk about some of the benefits related not only to clinical reasoning, but communication in our second objective. We'll get into some specific examples in our different programs and the way we use the RTSS to discuss these things. And then in the third objective, we're gonna be really frank with some of the challenges we've faced in doing this. And it's not really straightforward, and it can be time consuming, but we do really believe it's beneficial. As Susan said, we're hoping to engage and hear from folks about the way they've tried to use the RTSS or questions they have. And so we'll hope to have a lot of time to discuss that at the end. So to get into it, you know, these are kind of very basic questions for me as a rehabilitation clinician about clinical reasoning. What are you doing with your patients and why are you doing it? Those are, you know, for me, the heart of kind of clinical reasoning. And if we think about these questions in relation to the RTSS, you know, what do you do is really about treatment ingredients, right? You as a clinician, what are you putting into the mix to get your patient to do? And why do you do it is what is that change you're looking to see in your patient? So what is the target related to that? So I think these are things that you know, pretty much all clinicians and good clinicians and new and experienced clinicians think about, the RTSS really just kind of gives us a structure and a language to talk about these things really explicitly, which can be very helpful in teaching new clinicians, but also for experienced clinicians. So hopefully, if you're familiar with the RTSS, this diagram looks familiar to you. This is our tripartite structure, where we have on the left side ingredients, what the clinician is doing. And then we know the arrows of causality flow once the clinician puts ingredients into practice. They work through some type of mechanism of action to make a change in the target. And that's kind of the way causality flows. But we also know that when we're thinking about these things, so for the process of either treatment specification or really the process of clinical reasoning, things go in the other direction. So, we're working with our patient and we're trying to think about, what change do I want to make in my patient? What needs to change? And I'm going to first think about a target I want to identify, and then I can decide how do I want to change that target. And that's going to, be thinking about the mechanism. And then what do I as a therapist need to do to make that change in the target? So this is sort of the most common way I think that we think about the RTSS and its impact on clinical reasoning. But I want to take a step back and just introduce one more thing that we can think about in terms of the RTSS and how it can help us with clinical reasoning. So in order to do that, we're going to step back from the RTSS and we're going to think about, the process of rehabilitation treatments often start with goals identified by the clinician and hopefully in conjunction with the patient. So patient and therapist goals are usually we start with during this course of care. What do I want to help the patient achieve? And if we think about that and then how that's going to relate to the RTSS, the first piece of that is we really need to think about an enablement model. So if you remember from the RTSS, this is a representation of enablement, and our patient's goals are probably up here at the top. They're some kind of higher level. Often they're going to be related more to activity and participation. But I need to think about that model first, think about those goals up top, and then be able to break those down and say, what's the next step? So often I'm going to decide based on this enablement model that maybe for these higher level goals, I need to identify individual targets down here that are going to help to build up to change those higher level goals. Once I identify those individual targets, then we can use that previous diagram to really say for each of those targets, there's probably going to be ingredients I need to start thinking about. And I'm going to think about the particular patient presentation of my particular patient when I'm identifying those ingredients. So this goes, a little bit higher level to beyond thinking about targets in relation to ingredients. This pulls into the picture the enablement model, which is another piece of clinical reasoning and really complementary to the treatment theory piece that is what we usually think about in terms of the RTSS. So with that in mind, kind of those two pieces, I want to tell you about how we use the RTSS in some of our programs at Moss Rehab. So we have 3 different programs that we present the RTSS to together. So we have an OT Physical Rehabilitation Fellowship program. These are all yearly programs that run on the same cycle. So our OT fellowship program typically has 2 fellows, and there's roughly 10 mentors from throughout our organization that mentor in that program. We have a PT orthopedic residency program, typically with 1 resident and up to about 8 mentors involved in that. And then we have a neurologic residency program for PT with 3 different residents and roughly 15 mentors. So what we've been doing over the past several years is really heavily using the RTSS within these programs. One of the advantages of these programs is that we have time carved out explicitly to talk about clinical reasoning, and we have time carved out to introduce learning topics, which are definitely hard to do in the clinic when you don't have reserved time. So those are our basic programs. Really what we're looking to do, just as our webinar is about, is to facilitate communication and clinical reasoning within those programs, both for our residents and also for our mentors. So our mentors are clinicians throughout our programs, and using the RTSS, they have to really explicitly think about and identify their clinical reasoning processes to talk to the residents and fellows about. And that can be really beneficial, not just for the residents and fellows, but also for the mentors as well. And that's an explicit goal of these programs. And what we found is that, the more we can diffuse the RTSS throughout MOS with the strategy of working within these programs, we can get the staff more and more comfortable with these ideas, and we can use it throughout our staff as well. So those are kind of the broad ways we use the RTSS in our programs. And Mary Ferraro is going to pick up, and she's going to be identifying some more specific ways and that we use it within the programs.
Okay. Thanks, Sandy. As we introduced the RTSS relatively early in the year because it's used as a structure for the clinicians to examine their practice. The left side simply tells you how the mechanics of it. We do a lecture about it, but we have the residents and fellows do 4 assignments over the year. And with each submission, we have a group discussion where we go through and try to reinforce particular aspects of the RTSS and discuss their reasoning with their clients. We've intentionally modified it a bit over the years to make it less corrective and more interactive. And we're really mindful of the question when we say, why did you do that in your treatment? It really can be perceived as a challenge to their thinking. And in reality, though, many of these decisions are quite implicit for the clinician, and it sometimes can be hard for them to articulate why they did something, even though they probably had good reason and experience to do it. But we do find that by challenging them to explicitly state it, it does improve their ability to build on that reasoning and expand their practice over time. Next. As I looked over some of our old materials in preparation for this, there were certain common themes that come up a lot as we do these specifications. And certainly there's a learning curve for the RTSS. So in the beginning, we always need to spend some time to just reinforce some of the rules about how the RTSS works. And honestly, simply asking if the stated ingredients match the target goes a long way. It really helps therapists realize that they could be doing other things in the treatment, oftentimes keeping engagement, making sure the patient's engaged, that aren't necessarily changing the target, but are important nonetheless. But when you start to really separate that out, it helps them focus on what they're trying to change and the mechanism by which they're arguing that they can do it. Thank you. Sometimes functional goals like improved dressing ability aren't very informative because the target could be a barrier that hasn't been stated. So when I ask, though, the therapist can often tell me what the barrier is. And when we reduce the target down to that aspect of it, it becomes easier to make ingredients that'll match to be able to make that change. In our world, the distinction between skills and habits versus organ targets is always a common discussion because we do a lot of passive range of motion, strength, motor control, endurance. They're all common targets for us. Okay, next. Sometimes we can say, if I was a therapist reading your ingredients and targets, would I be able to deliver the same treatment? And it's a helpful way to remind therapists that to capture all the things that they're doing and these should be intentional decisions about the elements that they bring to their treatment. We are picky about terminology, and we end up usually in the beginning specifying some of the terms, such as learning is not necessarily performing. In the RTSS, learning typically refers to representation targets, and performing refers more to skills and habits targets. So when a therapist wants to introduce figure 4 setting, we really want to say to them, if that's the intent you want, you probably wouldn't be practicing it. So we want to think about, have the therapist be precise about what their terminology is. And that helps to make sure that their efforts are directed toward the output that they want. The real value, though, does come in when we think about ways to spark clinical reasoning. So in this example with the red box on the right, the therapist chose the same ingredient, the solo step, to work on 2 different organ targets for cardio endurance and muscle endurance. And we talked a little bit about what that progression might be and how it would be different for those different organ targets. Next. We wanted to provide an example of some of the specifications that we get from our staff. So this is a typical one that we would actually just a sample, an excerpt of one. We typically choose an excerpt that will allow us to make some RTS learning points in the discussion and to clarify some of the distinctions that are important for the therapist to improve their specification. We do always have the targets relate to the long-term goal at the top, and from an RTSS world, that would relate to the aim. That is the ultimate functional goal that the patient is typically working on. Next slide. 1 to 2 days before our discussion, we distribute these slides back to the staff so that they have time to think about our questions in relation to what they specified. And so you can see in this example, this may have been one that was pretty early in the year because we did a little bit more reminding them about terms. So the first target is really described more about what the therapist is doing, and we'd call that an ingredient instead of the target of what the person was actually trying to change. And here we also challenge the therapist about how they would measure safety. What does it mean about having better fastener management? What's the functional aspect of that? And so that terminology and that discussion prompts good thinking by the therapist about the precision of what they're going to deliver as a treater. Next. I wanted to give you another example. This is a PT submission. And this PT was looking at about 2 distinct organ function targets around hip extension. And you can see that one is for passive range of motion and stretching, and one is for strengthening. But the ingredients that would deliver that, next slide, Andy, thanks, are really quite different, right? Because they're going to be different ingredients to address those different organ functions. So that would need to be ideally 2 different lines, 2 different targets because of the components of the treatment. And then again, some of this terminology really challenges the therapist to split out and get right to the specific point that they're trying to change. We often ask therapists to bring their own questions about the treatment, and oftentimes the discussion ends up we learn more about the specific characteristics of that patient or their state or the state of the kind of personal factors that drive some of their decision-making, and that's helpful as well. Next. I'm returning to this slide that Andy already showed you just to reinforce that these therapists who now take these fellows and residents through their mentor forms, bring these discussions back out to the clinic and keep the conversation alive in our clinics, which we find a good way to foster this kind of thinking and clinical reasoning. Okay, now let me turn it over to Julie and Holly, talk about their work at Shirley Ryan.
Thank you, Mary. And let me just share my screen. I just want to thank ACRM for having us, and also Andy and Mary for introducing this topic. As Susan Lynn introduced us, I am Julie Carpenter, and I am a speech language pathologist co-presenting with Holly Paxson, a physical therapist colleague at Shirley Ryan. And Holly and I are co-chairs of the RTSS Electronic Health Record Task Force. So if you're interested in our work and interested in applications of RTSS and the EHR, please don't hesitate to reach out and contact us. I'd like to talk through today, basically some of the applications that we've been working on with RTSS here at Shirley Ryan Ability Lab as it relates to incorporation in our electronic health record, and more specifically focusing today on ingredients that are common across our rehabilitation professions. Our work originated through efforts to streamline our discussions around clinical decision-making and really to enhance the extraction of meaningful data from the health record. And for context, our organization includes inpatient, day rehab, and outpatient settings. Our system of care includes about 100 speech-language pathologists, 150 OTs, about 200 PTs, and around 130 students annually. And I really want to take a minute to acknowledge and pay gratitude to all of these other colleagues who are listed on this slide. It is really this group who has been doing this work. Holly and I are mere presenters today of all of this work, but to really call out our PT colleagues, Laura Doyle and Kristen Hole, our occupational therapy colleagues, Kelsey Waters, Caitlin Newman, and Jennifer Rickert, speech-language pathologist, Kelly Rogers, and then a very special thanks to Jana Ellison, who is an OT by background, but manager of informatics and data quality, and has been instrumental in helping with the EHR pieces of this project. Just a quick overview of what we'll discuss. We'll be talking a little bit about our project at a glance, and then more specifically, our process for identifying common ingredients. We'll talk through examples of our documentation pre and post RTSS, and then we'll talk about some lessons learned and open up the webinar for some question and answers. So our issue at hand at Shirley Ryan is really twofold. First of all, we have a lot of work underway to implement, analyze, and track outcomes data, including the application of a novel metric called the ability quotient. But we cannot currently pull meaningful treatment data on a large scale because it is in narrative form. We are able to incorporate some predictive modeling in the ability quotient to understand patient trajectories and know if that patient is on track with like patients, yet we don't know how our interventions are affecting progress. And thus we are running into that long-sighted metaphor, i.e. the black box of rehabilitation, whereby our treatments are not described adequately and really limits our understanding in terms of how they impact patient outcomes. And second, like Moss, we're constantly evaluating ways to improve clinical reasoning and decision-making through our various programs and mentorship endeavors. And it is really hard to evaluate what our therapists are doing with patients in our current EHR. Not only does the documentation fail to capture elements related to decision-making, but it is also very time-consuming to read and review documentation. So to meet our needs, we set out to pilot RTSS and clinical documentation, and each discipline pulled one domain to focus on as our experimental ground. So for PT, that was the arena of gait training. For OT, ADL performance, and for speech language pathology, we selected dysphagia. And we recognize that in order to more adequately promote clinical adoption or really diffuse RTSS throughout our clinics, as Andy and Mary were describing, we recognize that changing our clinical documentation was going to be a key step. Additional pieces of this project involved obtaining support from key organizational leaders, forming discipline-specific and interdisciplinary work groups to develop our discrete EHR choices. We are about to initiate a stage of building and piloting mock Cerner documentation. So this is a pseudo EHR domain where we can pilot this, collect and integrate feedback from clinicians and researchers. And then, of course, a big part of this project is to pilot some training and education, and then figure out how we can scale and sustain that across our clinics. For the purposes of this webinar, we're really focused on this piece related to the development of discrete EHR choices. And again, more specifically, those ingredients that are shared across our disciplines. And I will pass it off to Holly for the next segment.
Thank you so much, Julie. So for reference, our current Cerner documentation looks a little like this. For dysphagia is the top grid, and OT therapeutic activities is the bottom grid. So we have a treatment grid structure. Within each column, there are multiple choice click boxes as well as free text options, but the free text options do have a character limit. Dysphagia documentation also is built around food, liquid consistencies trialed, so any additional exercise-based treatment is completely free texted. Next slide. Our GATE documentation is similar to the other disciplines. However, many multiple choice selections are missing. GATE impairments are pretty generalized, and we also miss information related to dose and intensity. We know there is such a focus in our profession on specificity, and yet that is not really well captured in our daily treatment notes. In all of this documentation, it is really hard to understand targets, the rationale, or the specific therapeutic ingredients used. Often, clinicians are defaulting to free texting information, which leads to high variability in how clinicians document treatment. This is a problem for replication across sessions, therapists, or clinics, and it's also a big barrier for data extraction. So our first task was really deciding how we would integrate the concepts of the RTSS into the existing boundaries of our Cerner EHR. It was determined that our only option was to really continue with this grid format. So interdisciplinary work groups met to discuss and determine broad headers for each column, including primary target and active ingredients such as activity, feedback, cueing, position and environment, etc. We also had to take into consideration regulatory requirements, as well as information that is essential to be passed between practitioners via the medical record with regards to our column headers. Once the broader documentation categories were established based upon the RTSS manual and other publications, discipline-specific work groups met to tackle development of ingredients that were salient to the area of practice that they were developing documentation for. Each work group used evidence-based principles in areas of motor learning, neuroplasticity, skill acquisition, etc., to ensure that the targets selected had known or theorized mechanisms of action for each of the targets. As discipline-specific work groups began developing lists of ingredients relevant to the domain they were addressing, we quickly realized there were categories of ingredients that were likely shared across disciplines. So it became really evident that it would be super important to have agreed upon shared language and terminology that was consistent across disciplines, particularly in the areas of feedback, cueing, equipment, etc. And to date, those common lists of ingredients do not appear to exist, though there are sources in our respective disciplines that share language. So our process for developing the list of shared ingredients really began with us pulling relevant discrete choices from our current EHR, as well as reviewing the existing literature for the practice domains we were looking to edit. A key group of interdisciplinary content experts from our organization gathered to review the long list of potential shared ingredients generated by our discipline-specific work groups. And then we also obtained input from RTSS experts via the ACRM task force. The ingredients were then further distilled down through group consensus and congruence in rehabilitation literature or other sources such as the IRF-PI. And then efforts were made to ensure language and wording was consistent. So this slide just illustrates some of the sources just as an example, and recall that we're only discussing specific domains of practice like dysphagia or GATE. So this is just a draft of that process. This first screenshot really demonstrates the generation of various themes that captured our ingredients, including teaching training methods, cueing, feedback types, timing, practice schedules, environmental setup, devices, etc. Ultimately, we narrowed these specific categories down to capture ingredients for our interventions. So these were the final decisions for our column headers. It mimics what our Cerner pilot build looks like. On the left are the columns that pertain to targets, and then activities that are specific to gait, dysphagia, and ADL performance. And then within each of those columns, there's going to be checkboxes that pertain to those domains. Then the rest of the green columns represent shared categories such as assist in cueing, feedback, instructional methods, position, environmental considerations, etc. There's also some additional columns for sections that we felt, again, were really relevant to include in the medical record, but may not perfectly fit into the RTSS language, such as ancillary equipment. There might be reasons why a therapist might need to document that a patient is wearing a cervical collar or has a specific brace, but it's not necessarily salient to the particular target of that treatment. We also wanted to make sure that we still left an area of free texting for things that might happen in a session that a therapist needs to document. All right, so as we have gone through this process, we have currently specified 213 shared ingredients. Of course, we really continue to add, subtract from this list. It's very fluid at this point, and we've really only tackled domains of gait, ADL performance, and dysphagia. Each discipline will then select particular ingredients that are salient to their intervention domain for build into the EHR, so excluding those ingredients that may not be relevant. Our goal here is to really try to meet a trade-off between overspecification and documentation burden. We want these builds to represent relevant and active ingredients within a domain. So this is an example of one of our categories. It's our current drafted ingredients for the feedback and instructional methods category. And again, each discipline will then pull from this menu for what is salient for their particular area of practice that they're building. And now I'm going to turn it back over to my colleague, Julie.
Thanks, Holly. This is just a preview. It's really hot off the press as we are working with our Cerner team on beginning to build some of this pilot documentation. And the above screenshot is a pre-RTSS example of a dysphagia therapy that was documented. And then the second screenshot below is an example of pilot RTSS documentation. And this is in the domain of an organ function exercise. So what you can see is that in the prior documentation, there's a lot of information that is either free texted or not specific enough. In this example, this is trying to document a treatment called chin tuck against resistance, which is a strengthening exercise in dysphagia. And in the pre-RTSS version, there is really poor specification of the treatment target, very little detail on cueing, feedback, equipment. And in contrary, the RTSS documentation, you can see those shared ingredients much more easily captured, things like type of cues, models, support, feedback used in the session. And additionally, we can see clearly selected is the target and the ingredients that are selected to impact that target. This is a different example in the domain of skill and habit training, again, related to dysphagia. And in this case, in the pre-RTSS example, the documentation seeks to capture trials of liquids and pureed foods. And again, in this case, there's no clear rationale for the treatment, and the type of cueing, feedback, et cetera, is still really challenging to distill. In contrast, in the pilot version, there's much more specification of these particular ingredients. And you can also see those targets clearly defined. So some of the pieces that we've taken away from this shared ingredient project have to do with the inconsistency of disciplines and use of terminology. Things like visual aid, external aid, scaffold, direct or indirect cues, all have various meanings to our different disciplines, and have really had to take a closer look at what these particular terms mean and how we can come up with more shared language. Additionally, we've really had to balance the thoroughness of the documentation with acceptability and feasibility. We want documentation to be digestible and reasonable, for what we expect clinicians to be able to perform routinely. We've had various discussions on what are active versus inactive ingredients. So for example, OTs might find that the positioning of a patient to be much more relevant than the speech language pathologists, or an example that Holly mentioned earlier with the cervical collar. It might be really important to capture that in documentation, yet is maybe not clearly impactful on the particular gait target that is being targeted in that therapy session. We're also attempting to balance the documentation needs for experienced clinicians versus new hires or new grads and students, and considering what the training will need to be as clinicians enter the organization to begin to adapt to this documentation immediately. Another challenge is really capturing dose when we're thinking about capturing how our interventions are delivered. And specifically, we are trying to balance the need for something that is easy to extract from the medical record, but is also clinically feasible to document. And as we've increased specification, we've also collaborated with our compliance teams to ensure that we're meeting requirements. They happen to be excited by RTSS because of how much more specific our documentation is, but nevertheless, that was a concern as we've gone on through this project. And then a final consideration was really one that was more of pragmatic design and limitations of our EHR platform. So our original idea across disciplines was to somehow constrain ingredients when a certain target is selected, yet that was just not executable in Cerner. So we had to go for a much more simple and pragmatic design. So that's really some of the main pieces from our pilot and the lessons learned as we've explored these shared ingredients across disciplines. And now I'd like to open it up for the Q&A. And Susan, I think maybe I'll stop sharing my screen for now so that we can easily see each other.
Great. Thank you all for that wonderful presentation. I also wanted to encourage everyone to type in their questions into the chat, and we will take them in order. I do have one question so far for Andy and Mary. How did you measure improved communication and clinical reasoning at Moss Rehab?
Well, I'll start, and it's a challenge. Recently, we've started using a tool called a clinical reasoning tool that we've done at the beginning and at the end of the fellowships residencies. So now it's our third year collecting that data. It is it's a tool with Likert scale items with regarding people's confidence in their ability to clinically reason. So we don't have a lot of data at this point, but that's one way we've tried to capture.
Okay, thank you. And here's another question. For those of us considering the use of the rehabilitation treatment specification system in our EHR system, how long would you estimate the process takes to create a mock build?
That's a great question, and I think I'll try to tackle that. So I think that there's kind of two pieces to that. The first piece is that we really had to develop sort of the targets and ingredients that we would propose to be built. And that process from our interdisciplinary group, the team members that I had shared on the screen, that process has taken us about 1.5 years just to kind of identify, understand RTSS a little bit better and begin working through our particular domains of practice to understand what it is that we even would want to propose to build in our documentation. In terms of the actual build, we have some internal resources to modify our Cerner documentation at Shirley Ryan, which is, which is unique. And with that, we are able to collaborate with them sort of throughout the process. So I would say over the last 3 months or so is really when we've picked up with meeting with the information system team, beginning to plan how this will be built, what it will look like, beginning to test the documentation. So we're at the phase right now of really just testing out the documentation before we would consider then releasing it into the wild, for lack of a better way of describing it.
Okay.
And one thing I'll add too is that we're sort of doing, we're titrating out like what we're doing. And so speech is going first, but once we start already building in some of the key shared ingredients and targets, that will already then exist in sort of the background. So it makes it much easier then for the next build, which is going to be PT, and then for the next build, which will be OT, because those ingredients and targets are just being built on top of each other. And so they don't have to recreate the wheel every single time. So kind of once the initial build went in, it'll be much faster for the other domains to be put in as well.
Great, thank you. And Claudine Auger asks, are you using outcome measures?
As far as patient outcome measures, yes, we have a large battery of outcome measures that we have standardized in our system of care that we routinely administer: PT, OT, SLP. Those measures are in flux as we reconsider what might be appropriate for our other levels of care. In terms of outcome measures for this project, I think what our group is specifically interested in measuring are things like the alignment or the number of times, for example, targets are mentioned in treatment documentation, the alignment of ingredients with targets in the treatment documentation. We're interested in knowing how many of the ingredients that we've built are actually then used. We're interested in knowing how many of the targets we have built are actually then used, and do those things differ by our sites of care? For example, is there a certain site that may be lagging behind with using a certain target or a certain ingredient? And does that help us direct our education and training efforts more, or our mentorship efforts more at that particular site? With our mock rollout, what we are also doing is surveying clinicians about their use of the current Cerner environment with this mock environment. How do they compare the two? We want them to actually, as part of the pilot, we will be having them double document. We're giving them some extra protected time to do that, but we will have them document in both environments so that we can really get a snapshot side by side of that clinical documentation for that given treatment session. And then we really want to compare the time. How long does it take them in one method versus the other? And then get their feedback kind of on those exact, in that exact environment. Was it sufficient for capturing what they needed to capture for their treatment sessions?
And I will say that I presented, I'm also a manager here at Shirley, Ryan. So I presented to all of our managers at all of our various levels of care and clinics regarding this project that we're rolling out. And that was one of the big key concerns from our manager levels was, how long is this going to take? That's what my clinicians are going to ask me. Is this going to take me twice as long to document now as it did before? And so there was a lot of concern around that. And so I think that's really going to be important for us to show and show that there's a progress as you get used to the RTSS documentation, that your time and your efficiency will improve. I think that's going to be a really key component to buy in.
I'll mention, with regards to kind of tracking outcomes in relation to the RTSS use, that's a conversation we have frequently in different RTSS applications all around. And we've tried to do that in different ways in different projects at Moss and other places. As Mary said, we use an assessment of clinical reasoning. Typically, when we introduce the RTSS and when we train staff on it, most of the staff will say that they like it and they find it helpful and they find it, improves their clinical reasoning. But again, being able to track that is really difficult And, we don't think we're at the point that we're going to be able to see, outcomes, changes in patient outcomes through, teaching one clinician or something, the RTSS. But I think, the strategy for Julie and Holly of introducing the EHR and making that big change, and then can you see the impact on patient outcomes is a great way to look at that.
Andrew, when you implemented the RTSS at Moss, did the clinicians also report that an increased efficiency with their documentation?
So we don't have it in our documentation system. So
Oh, okay.
yeah, so we weren't able to do that. We have colleagues in the UK who used it for a clinical project, and they actually they did some objective tracking. They tried to monitor clinical conversations like in structured settings such as rounds, and they tried to see if they could identify increased usage of RTSS terms in some of the documentation after they had introduced the RTSS for clinical reasoning purposes. And although the people that they trained, again, said that they found it helpful and they liked it and they thought it improved their clinical reasoning, their results in their paper they weren't able to capture increased usage of the communications and the terminology. So it is difficulty, being able to demonstrate an effective change.
Okay. Let's see. Thank you. We have a thank you for this presentation. The content was delivered very clearly. I'm wondering if any of the presenters have seen RTSS implemented in a preclinic setting, undergrad, grad school, to help foster development of clinical reasoning skills.
Yes, we've seen that in some local Philadelphia schools. I've given a lecture, and it's actually been the basis for one of the ways that a class wrote their treatment plans, and it was a framework that the students found helpful. So, but it's so some of our local schools have felt that, and and there is an aspect of from the ACRM networking group of educators who are developing materials to use in clinics. So I think it is getting out there, though it's somewhat inconsistent.
Thank you, Mary. We also have Barb Shell asking, she's wondering about the interface of RTSS with intervention fidelity.
Oh, well, I think it's a perfect way to think about fidelity and be able to capture what therapists do. But I will say the RTSS doesn't, you can specify a bad treatment too. So it's really the practice of getting it out there in a systematic way that can be discussed and measured and delivered and speaks toward fidelity. But and that's why our question is, if I delivered this, if I read this, would I be able to deliver that treatment in the same way? Really comes to the fore again and again, because clinicians do more than they realize and don't capture it, or they do things that really aren't serving the target and don't realize it.
Thank you. I also want to just throw out just a wild question, just want to know your thoughts. It's kind of out there. Do you think artificial intelligence could play a role to facilitate the use of RTSS in practice?
It can play a role in everything, right? Now that's what we're kind of learning these days. But sure, I mean, I think it could learn the RTSS system pretty well, and then kind of maybe help us figure out how to employ it a little bit better. So that I would kind of say that, I'm excited by the prospect in general. In terms of treatment fidelity, I think too, I just want to go back to that. I think, again, sometimes clinicians say they're doing the same thing, every clinician is doing gait training, but you look at them and you can see that they're all doing different things. And again, clinicians can explain that. We can identify different components of that, but not in a systematic, explicit way. So, for me, the RTSS it's a lot about, things that a lot of clinicians are already doing. It's just helping us to organize them and think about them and communicate them in a sort of systematic, explicit way, which I think is really valuable.
And I think one of our big aims of this project was just that, even though we can't really drive the clinical decision-making because of the limitations of our Cerner documentation build, we do want to hopefully have clinicians really stop and think about what they're doing. Why are they doing it? Why are they choosing X, Y, and Z? And if they can't figure out why they're doing it, then maybe they need to be shifting gears a little bit. And we're hoping that this will help really force clinicians to stop and really, kind of consider some of those things.
We have a question. Are any of your sites participating in the Care for TBI project? I was wondering how compatible incorporating the RTSS into your documentation system was with the standardization efforts that are already occurring as a result of that project across the many TBI model system sites.
I can speak to that because the Moss is involved in that project, and Mary Ferraro and I are both kind of involved with the that project. And actually I call the Care for TBI sort of informed by the RTSS. It's not down to the level of, identifying individualized ingredients, but it's trying to take a step there. One of the original creators of the RTSS, John White, is on the advisory board of that Care for TBI project. So he's been informing that. And it's trying to get at some of those ideas, but in a way that it can be employed throughout 16 model systems and all their individualized electronic records in a systematic way. So it's, I think, a small step towards the RTSS. I don't know if you have anything to add, Mary.
No, that was perfect. It's a small step.
Are there any other last questions? We're down to our last few minutes. Well, we'll see if anyone's typing, but I just wanted to thank all our excellent speakers this afternoon. And I want to thank the audience for attending and participating. The recording will be available in the next 48 hours on ACRM's website. I posted the link on the chat if you want to save it for later. And there are also other webinars you may be interested in if you want to learn more about the RTSS. We also want to invite you to attend our ACRM RTS networking group annual business meeting at conference. ACRM conference is this late October in Atlanta. And you're welcome to join our group to learn more or to help apply the RTSS to your work. So thank you very much. I don't see any other questions, just some thank yous. And we hope to see you at another RTSS event or ACRM event. And have a great day. Thank you all.